I'll be your orthopedics course director and also your primary instructor for blocks 1 through 3. And then you'll have Colonel Sylvester for block 4. I'll still be involved in all aspects of instruction though, okay? So the intent for this initial presentation is just to do a little introduction, okay, kind of do some rules of the road, get some stuff out of the way, answer some questions, and then we'll get into our first topic of the day, and then I'm going to let you guys go, okay? Because I can see the meters are kind of low already, okay? I'm under no illusion that, 1500 or 1430, I should say, is your favorite time of the day. And my house is actively flooding, so I need to go attend to that, okay?
Oh no.
So, instructor introduction, right? We're going to talk about expectations, available resources, study tips, assignments, right? Which I've been told, call them activities, right? Because people are like, assignments. No other courses have assignments, okay? Not high threat. They're meant to prepare you guys and get you guys in the mindset of orthopedics, okay? I know a lot of people have some reservations with orthopedics. We're going to get past that. You all are going to love orthopedics by the time you're done with this, okay? Or at least you'll think better of it. Good to go? I'll take that one. So as it says at the bottom there, the body is your best study aid that you have. And guess what? You can bring it with you to every single exam, okay? So it's not unusual for me to look up during an ortho exam and see somebody doing some kind of weird finger thing or some kind of weird contortion thing, trying to think about what process is occurring, what nerve root is involved, what reflex is being tested, etc. Okay, so remember that, okay? Short of using another person's body, using a body is something that you should start getting used to thinking about, okay? Meaning practice on each other, okay? Appropriately, please. So who am I, all right? So I am the guy in the top picture there. This is all I could find. Okay, so you're welcome. I'm also the guy in the bottom picture there with my family. Okay, so as you can see, it's very confusing because I'm wearing an Air Force uniform. Okay, so who am I? I have 27 years combined service now. I just clicked that meter over. Okay, it's actually closer to 28, but whatever. As long as I get my retirement pay correctly. So I'm a prior United States Air Force medic. Having said that, I did a lot of stuff in the medical field. I joined in the 90s. I went through special operations medical training. I was detached to the Army. I worked for Southcom. I did a bunch of really cool stuff. Some people would say crazy stuff. Okay, but I rose to the rank of E7 because I didn't say no to anything. Some people would say that's stupid, right? I wrote a lot of curriculums. I wrote a lot of training programs that still exist in some way, shape, or form across multiple services. Okay, so I have a BS, right, Bachelor's of Science, in kinesiology. I'm an exercise physiologist. Okay, what does that tell you? I love musculoskeletal because I'm also an orthopedic surgery PA who graduated a fellowship program at Naval Medical Center Portsmouth. Okay, I actually attended PA school civilian. Because back in the day, even though I was an instructor across base at DMRTI, Defense Medical Readiness Training Institute, teaching all kinds of crazy stuff, I couldn't get in. They just didn't have the slots. Now I look around and I say 71 people, holy moly, right? That's a lot of people. I couldn't get in back then. The classes were way smaller, okay? So I went to PA school and I got my first tuition bill. And I was like, holy Jesus, how in the heck am I going to pay for this? Because I had separated from the military completely. Free and clear, guys. 13 years, E7, done, moving, right? Got my GI bill, I'm good to go. Yeah, PA school is expensive. I went to USC, that's Southern California. I am not a Gamecock, okay? And then I was like, well, let me apply for some scholarships. I put in for a bunch of scholarships. I got the HPSP, right, Health Professional Scholarship Program. I was one of the first 10 selected to the Navy, even though I was Air Force, because I worked joint operations doing that crazy stuff I talked to you about, and I got some good recommendations. So then I went on to the Navy for 10 years and did that, okay? The list is long, but I did a lot of stuff. Again, a lot of stuff on the operational side. I worked with Naval Special Warfare, Marine Special Operations, dive communities. I was OIC of a MEP station. I was this, I was that. I was department head, et cetera, et cetera, et cetera. I worked in internal medicine. I worked in family practice. I worked in pediatrics. Like I said, I ran a MEP station, so I worked in everything essentially. Physical exams department head. I was the entire authority, if you will, for the Naval Pacific Rim. Okay, and I was just saying the Pacific Rim because I was it. Okay, so I'm familiar with a lot of different services, profile systems, and programs. All right, so that's enough about me. Not my favorite topic. But I will tell you that I've been some interesting places. I just came from Misawa Air Base, where I was the chief of surgery. Not the chief PA of surgery, the chief of surgery. I was in charge of all surgical services, everything. General surgery, urology, et cetera, et cetera, et cetera. Oh, and by the way, orthopedics. Okay, I was there on trauma call for 3 years, 7 months by myself without a surgeon, in charge of the entire scope of orthopedic surgical care for the northeastern portion of Japan, and some would say the Pacific Rim. So what does that tell you? I love ortho, but also I'm coming from the trenches. You're getting me straight out of the trenches. So I'm gonna teach you things that will hopefully make you better when you get out there and start practicing. Good to go? You're not just gonna get didactics from me, you're gonna get some real world stuff too. Okay, because that's the value. Right? So the most important part of this presentation is the bottom there. I'm married, I have 3 boys that I know of. Okay, their ages are listed there. My wife is a prior medic as well. She's a nurse. I don't hate nurses. Don't let the previous junior class tell you I do. I do not. My wife is a nurse. I make smart little comments. As you can probably tell, I'm pretty sarcastic. Okay, that's what keeps me going, keeps me lively, keeps me fresh, keeps me frosty. Okay, there's a picture at the bottom there of us in Okinawa. If you guys have ever been stationed in Okinawa, I know somebody in here probably has been there. That's the aquarium, okay, down there. It's one of the best aquariums in the world. If you ever get out to Okinawa, definitely don't miss out going there, okay? Because you can take goofy pictures like that as well. Okay, so what are my expectations for you guys? Be on time, be prepared, okay? Read, read, read. Before I give any lecture, before I give any lab, before I teach anything, I read. Why? Because you can always be better at something, be better at communicating something, be better at performing something, as long as you're fresh and refresh, I should say, on the current data and the current information, okay? You guys do have the lectures now for the entire block. They're uploaded. So if you want to read ahead, please do so. Okay? Ask questions. Please ask questions. I beg of you. Because again, like I was telling my group earlier, in Clencor, the whole reason I'm here, guys, is to educate. Because I have no free time, I decided to get a doctorate in medical education. I just completed it, okay? So I literally have an interest in medical education, specifically in PA education, okay? But I have been teaching residents, surgical residents, medical students, excuse me, nurse practitioner students, paramedics, which I was one as well, for years. So again, my interest is in teaching you guys. So ask questions. Come to my office if you have more questions. Text me. You're going to get my phone number, right? It's on the syllabus. Text me. There's never a dumb answer. The only one that I would say is a dumb question. The only one that's a dumb question is probably the one I ask. Okay? But short of that, ask questions. Good to go? Practice exams. That's not like multiple choice test taking. That's literally physical examination testing. Okay? Special testing, range of motion, reflexes, neurological assessments. You need to practice these things, okay? Because guess what? If you practice them here, you'll be more proficient when you show up to phase 2, right? Your exams are still gonna suck, all right? Not really, hopefully not, right? You'll still have some area for improvement, but the more you practice, the better prepared you'll be. my motto is bleed here, right, at IPAP, so you don't die out there, which is the real world, right? And more importantly, you don't cause harm to your patients. And you understand the disease processes are occurring because you know how to do a good physical exam. And tie those in with your imaging, your knowledge, all that stuff is between your ears, right? All that stuff you're learning now and you're going to continue to learn. So practice your exams, please. I am here to help you practice as well. And seek assistance when needed. If you need help, let me know. I will constantly ask you guys how you are. How are you doing? What is going on? I will hear things, right? You guys have concerns. You guys will have issues throughout the semester. Keep me engaged. I'm not just an orthopedics instructor. I'm also a mentor for you guys and a resource if you need me. Good to go?
Sir.
Available products. Okay, a great amount of time has been put into this course. Okay, so there are resources already loaded into Canvas. Some of the things in there you'll find are clinical cases. Those are literally specific clinical cases to the systems, right? Upper extremity, lower extremity, spine, that we're studying at the current time, okay? Use those to sharpen your skills as you're practicing as well, and also to prepare yourself mentally for what? OSCEs, right? Mock OSCEs and then OSCEs, okay? I'll tell you right now, the mock OSCEs, yes, you should do well, right? You want to pass them, but the OSCE itself at the end of the senior year, you must pass them. So the sooner you start practicing that stuff, the better off you'll be, and that's why I provided you guys clinical cases. Good to go? All right, videos. There are physical exam videos in there. I'm changing things up. Those videos will be used as a general primer, if you will. And then when we go into our lab sessions, which we'll discuss more specifically as we get closer to them, I will do one-on-one, or one-on-71, I guess, instruction to show you how to do an exam. I don't want to watch you guys do them wrong for 2 hours. Make sense? That's a joke. But that's something that one of the students told me before. If we could get someone to actually show us how to do them correctly, that's huge. Because most instructors assume that when you go through your clin skills, right, that you guys know these things. I don't assume anything. I want to know where you're at, and therefore I will teach you at a baseline, and you will build from there. Good to go? Readings. Okay, so let me get this out of the way. Yes, you have a textbook. Does anybody have it in the classroom right now? No? It's not light, right? Yes, it's available online through AULS, whatever that stands for. It's a university thing over there, right? So, but I have provided you the readings in PDF format for the what we call the high yield topics. Okay, so if you go into Canvas right now, you can go into those high yield topics and look at their highlighted readings. Why are they called highlighted readings? Because they're freaking highlighted. Okay, there's literally areas in there that are highlighted. Good to go? So you should look at that. Don't just be the kind of person that says, well, I'm just going to read the slides. Will you pass? Maybe. Will you be as knowledgeable as you possibly can be in your time here? Probably not. Make sense? Okay? Read. Then there's what's called reading sheets. Okay, you'll find those too for every specific pathology that we're going to encounter, right? So that's what this is. This is a reading sheet. You're supposed to use this as you're reading and as you're studying to break down the different pathologies or different conditions and get a sense of what that condition is and how it compares to other conditions. What is that called? That is called a differential diagnosis, people, right? Are you going to be asked two differential diagnoses in your mock OSCEs and your OSCEs? You are. So again, these are meant to help you. I will not be grading these. Okay? Whew, thank God. There's like 16 for block 1. Okay, I get it. I've been a student too, right? PA student a long time ago. They're not for a grade. But if you do them, right, complete them, and you give them to me, and you ask me for feedback, I will provide it for you. These are meant to help you study, to help you prepare, not just for the exams, but also for phase 2 and beyond. Good to go? Use the differential diagnosis section of the reading sheets. And again, that's going to help you start thinking about things in the sense of what else could it be. I will tell you now that you will commonly hear from me, what's the worst thing it can be? That will be listed here as well. If you miss that, like Captain Lane said earlier, the worst thing it could be, do you think you could cause harm and or death of the patient?
Yes.
Yes. So I want to start getting you guys used to that mentality. Good to go? Okay. Again, this is kind of showing you there how it has it highlighted, the condition, clinical presentation of it, signs and symptoms, physical exam findings, imaging and labs that are pertinent, treatment plans, right? Management plans, and red flags. What are red flags? Red flags are those things that, again, if you miss, you could cause harm and or death. They're both bad, okay? And this is how you start thinking about it. Remember how I told you you can study on yourself or each other appropriately, please, especially in public? This is kind of how you can use that as well. I'm not expecting you guys to draw on each other, but this is an example of how people study at medical universities, okay, when it comes to certain pathologies. Good to go? Okay, the key is to synthesize information, not just copy it. That's why I'm telling you, I'm not going to grade these, right? Because this is for you. This is for you to use it to study. I don't want to see you do a copy job, right? This is not grade school. We don't want to see you copying things and turning them in. There's no value there. Does that make sense? Okay. Assignments. The assignments, again, I'll call them activities, fine. They're meant to refresh your anatomy. For some of you guys, anatomy class was a long time ago. Yeah, you did the thing here, but this is ortho. We go a little bit deeper, right? This is not gross anatomy, superficial anatomy. We go into some specific pathologies. So the whole purpose is to get you guys thinking about that relevant anatomy again, and also how radiographic findings correlate. Make sense? Okay. Whoops. That'll be completed during class. I can be loose on that. That's fine. You're supposed to turn them in within 72 hours. I'll be loose on that as well, depending on what's going on. I know I'm not your only class. I'm your most important class, but I know I'm not your only class, right? And why do I put the self-selected images in there? Because it's a way to let you guys know, hey, if you see these things on a test, what's that test you guys are going to take pretty soon? That big test, like at the end of PA school? PANCE, right? So I'm going to try to prepare you guys for that as well. Okay, because PANCE loves to throw common things at you, right? So if I can give you a little bit of insight into the things that they may throw at you, the better we are, right? Good to go? Any questions for me about that? I don't start the lecture until I get at least 1 or 2 questions. So somebody give me a question. Nobody? No questions? All right. You guys are shy? We'll get you out of that. All right, give me a second to switch over because I got to do this manually. So. Any questions about the syllabus before I move on? Has anybody actually looked at the syllabus? All the syllabi, did I say that right? Yeah, syllabi, have been updated for every course because we just had an RPA review, right? So I have taken painstaking amount of detail to give you a course schedule that outlines how this course is going to flow. Okay, don't everybody just cheat and find the one person who already knows the curriculum. Things may be a little bit different. Okay, so anybody looked at it? No, just be honest, it's fine. All right, look at it. Let me know if you guys have questions. My phone number's on there. Do you guys need a break? No? Okay, perfect. That's the right answer. All right, so we're going to talk about orthopedics. So just to begin with orthopedics, the first block is general orthopedics and spine. Okay, so when we think about general orthopedics, I want you guys to think about one thing. That's me introducing you to some general concepts in orthopedics, okay? Kind of like a primer, if you will, right? And then we go right into spine. I can tell you this, as an orthopedic surgery PA, I hate spine, okay? Because spine is one of those areas that patients present, usually it's not the best day of their life, and guess what? There's not as much joy in the surgical procedures because only the person staring into that hole can do anything, right? But spine's also scary because it has a lot of implications. When you guys did clin skills and you talked about spine, you talked about neurologic findings, right? Neurologic assessments. That probably made you guys nervous. We're going to go through all that stuff. We're going to talk about nerve roots. We're going to talk about reflexes. We're going to talk about dermatomes. We're going to talk about myotomes. And hopefully you guys won't be as freaked out as my kid says, okay? So the objectives of this initial lecture today, we're going to talk about some principles of musculoskeletal evaluation. Again, just to get you guys thinking about how are we going to do these labs? How are we going to practice these exams, okay? We're also going to talk about fracture evaluation and management principles. That's something that got added this time around because it was towards the end, and then it just kind of you got hit with it, right? So I wanted to give you guys kind of a primer and just talk about some general concepts, okay? Nothing too in depth. We're going to talk about operative versus non-operative management principles. We're going to talk about NSAIDs versus corticosteroid injections. A lot of questions about that, okay? And we're going to talk about the first main topic, which is arthritis, specifically osteoarthritis, okay? So, to begin, when we talk about principles of musculoskeletal evaluation, it's important to understand that patients present with pain, stiffness, deformity, and or weakness, okay? Can they present with a combination of all those things? Yes, right? But what I want you guys to start thinking about is when you guys are doing your review of systems and you're asking questions of patients during your junior clin core and during your practices in my labs, in our labs, right? These are the kind of things you're going to be looking for. These are why you're asking these questions. Because you're trying to zero in on the body part that's involved, right? That picture is kind of like supposed to point you in that direction. Where's the pain, right? So one thing you guys want to get to understand too, when you're doing your assessments, is if you literally ask the patient with one finger, point to be where it hurts you the most, that can give you a lot of information, right? The other thing that can give you a lot of information is a history, okay? You guys probably remember it as OPQRST, correct? Okay, some things that are specific to orthopedics are temporal factors, or temporal factors if you're fancy, okay? So temporal factors include things like weather, time of the year, time of the day, time of the week, things like that, right? Do patients sustain injuries, certain injury patterns more so during the winter months? Yes. 100%. I love winter. I love trauma because guess what? That's awesome surgery. I'm at the point in my career where I can do a lot of the surgery, and I've been teaching residents to do it for years now. So if I get somebody who comes in with a fresh ski injury, I'm super excited, which is weird, right? So physical exam components. Every physical exam, no matter what body part you guys are talking about, starts the same. Inspection, what am I looking for? Right? Palpation, what's your bony landmark, that you're palpating? Range of motion. Every body part, joint, etc., has a specific range of motion that's considered normal limits, right? So we'll start talking about those and thinking about those, okay? Manual muscle testing, that's at 0 to 5 out of 5 strength, right? Is that compared to itself or compared to a contralateral side? Contralateral side. So it's the affected side, thank you, that was the right answer. Got my first involvement. So 0 to 5 out of 5 compared to the contralateral side. So if you're just comparing one side to itself, is that significant? No, it may not give you the full story, right? Okay, so sensory evaluation, I will tell you this, you guys are taught to do sensory evaluations in a certain way, okay? You know, the wisp, the sharp, the light and the dull and all that stuff, and you're wisping all over each other. That's fine, we'll continue that here. But I will also teach you how to do a neurological assessment, neurovascular assessment, excuse me, that can do a quick down and dirty assessment in a trauma scenario, for example. Okay, that's how orthopedics tends to function. Make sense? With the exception of spine, right? I know, everybody hates spine. But we'll get through it, I promise, okay? And then special tests, I put that in red. Why do you think I put that in red?
Important.
Because it's important. Every time we go through a system, that was the right answer, thank you. Every time we go through a system and I throw a special test out to you, do you think you might see it on an exam?
Yes.
100%, okay? So if you're doing a lab and there's a special test you don't understand, you should probably say, hey, Major Davalos, can you explain this to me or demonstrate it to me? More so than I already have, okay? Make sense? So remember that. If there's a special test you don't understand, meaning you can't describe it and know what it's for, right? Is every orthopedic exam, special test, excuse me, is every orthopedic special test a test for pain? No. Some of them are tests for weakness, right? Some of them are tests for deficits. Some of them are tests for defects. Good to go? So now we'll talk about some fracture evaluation and management principles. There's your definition of a fracture. Pretty dull, right? It's a broken bone. Okay, but it's a disruption in the continuity of the cortical surfaces of the bone. Okay? There's different kinds of fractures, and we'll talk about those. But it is important to understand how to characterize a fracture, because the management of the fracture will be dictated by that, essentially. Okay, so if you understand the fracture you're looking at on an x-ray, and the deformity you see on physical exam, and the deficits you find on physical exam, then you understand how to manage it better, okay? You guys are all going into primary care, at least initially, right? Then you'll find your way into other specialties potentially. But you need to know how to recognize certain conditions based on their presentation. That way you know how to disposition them properly. Make sense? Yes? Maybe? So selecting the proper imaging modality is essential. What do I mean by imaging modality? You guys already have radiology, right? So we know there's things like MRIs, CTs, ultrasounds. You know, there's certain conditions in orthopedics we'll order ultrasounds. You're like, really? Ultrasound for orthopedics? What was that? Well, we do have some vascular conditions that orthopedics is concerned with, right? Can we look at tendons on an ultrasound? If you're trained, you know what you're looking at, 100%, okay? So it's important to understand how to master those things and use them appropriately. Okay, there's some examples of imaging, duh, you all know what those are. But what's in red there? Yeah, so at a baseline for every injury or condition that presents, you're gonna order x-rays, okay? You're gonna order the appropriate x-rays, okay? So if you're doing a PANS test, yeah, you're taking a test, it's PANS, and it says what's the best initial diagnostic choice for this condition, and one of the choices is plain radiographs. Is that the right answer? Yes, that's the right answer. Every orthopedic condition gets plain radiographs at a minimum. Make sense? That's why it's in red. Okay? And you guys are going to see that over and over and over again. Okay, so if you're an astute clinician sitting in your clinic 3 years from now, and you call orthopedics, and they say, hey, you start saying, oh, this patient's got a fracture and all this, et cetera, or whatever, and the orthopedic person on the other side says, what do the x-rays show? And you say, oh, I didn't get x-rays. What do you think they're going to say to you? Call me back when you get x-rays. Exactly. Because we're super confused. My x-ray vision sucks, right? So I can't look at the patient just, standing there and tell what they got going on. So get x-rays, okay? MRIs, a lot of times, they'll be used for confirmatory purposes, so as to confirm a diagnosis, okay? And we'll get into some specific stuff like bicep tendon ruptures, Achilles tendon ruptures, Some conditions, you don't need them to make the diagnosis, but you need them to confirm the diagnosis. What's the extent of the injury, for example? Good to go? MRIs, we very commonly use for surgical planning. Okay? It's also used for soft tissue evaluation. right? So an MRI is really good for things like meniscus injuries, ligament injuries, right? X-rays, can you see ligaments and soft tissue on X-rays? No, right? You're still gonna get X-rays as a baseline, but then maybe you'll get an MRI. Spine, we'll talk about spine while we use MRIs, spinal emergencies specifically. Just remember for MRIs or CTs for that matter, hopefully not X-rays, you gotta start considering that kids, right, pediatric patients, are going to need sedation potentially to be able to sit in that tube for however long it takes. Has anybody ever gotten an MRI in this room? Besides the old man and me? Yes. So you know that when you're in there, how long are you in there for? 45 minutes? Yeah. You think a kid, like a 5-year-old kid's gonna sit in a tube for 45 minutes without moving? No, right? And is the study useful if they've been moving the whole time? No, right? So sedation is something you would need to consider. Okay, so what does that mean? Why am I telling you this? Because if you're going to order that study, make sure there's value. It's gonna change your management depending on what it says. Make sense? So if you need to order CT, get a CT. If you need to order MRI, get an MRI. But don't order the wrong one, because then you gotta put the patient through double sedation. Good to go? Okay. So CTs, again, for surgical planning, fractures at joints. That's a common theme you're gonna experience in orthopedics. When we talk about intra-articular, right? Intra-articular, meaning involving joints, okay? Fractures will very, very often get CT scans. Even us. You can see the fracture on the X-ray, right? But then we get a CT so we can further characterize it and for surgical planning purposes, okay? Why do we do CT scans in trauma? Because we live in an age where when somebody experiences trauma, we CT them from their head to their toes. That's what we do. We look at all the soft, squishy things. We look at the bones, everything. Okay? If they're stable, though, you see that in parentheses? You guys will see that again in senior year. You do not send an unstable patient to a CT scanner unless you want them to be DED, which is dead, right? You resuscitate them first, then you send in a CT scanner. Because no matter what the CT shows, it's a post-mortem CT. Who cares? All right? Good to go? So again, it says there may need sedation for Pete. Okay? Types of fractures. Woo! This slide's busy. Okay? This is just meant, again, to be a primer for you guys. But as you look here at this slide, you can see there's different fracture patterns, okay? You'll see this again way in the future in block 4, where there's specific fractures that are thrown at you. Okay, but just I want you guys to start thinking about things like open and closed, right? If it's an open fracture, is that more likely to get surgery?
Yes.
Yes, right? So that's one way to characterize it. And then what's the fracture pattern? Is it oblique? Is it transverse? Is it spiral? Right? Is it Y-shaped? Is it intra-articular? So just take a look at that slide. You will not see any questions on block 1 testing with fractures, okay? Specifically classifying fractures. But I want you guys to start thinking about these things, because you will hear these things when I go through certain pathology about intra-articular involvement. So I want you to have some sense of what we're talking about. Good to go? Ooh, that slide's busy. All right, so what is operative versus non-operative? This became an issue in the previous class where it's like, well, what is operative, right? So operative is anything that's done for the purposes of performing some kind of surgical procedure. Okay? So as you see on the right there where it says operative management, it can be anything with general anesthesia. It can also be regional anesthesia, right? It's like a block. Okay? If there's instrumentation involved, that's operative. Okay? That doesn't mean like we're using the instruments, right? Like pickups, scalpels, things like that. That's not what we're talking about. Instrumentation means putting stuff in the patient that wasn't there when they were born. Okay, that's what that means by instrumentation. Good to go? A lot of times with operative management, you guys will work them up, the patient. You guys will treat them for a while, send them to all kinds of conservative care, and then we'll decide, well, we've managed all the non-operative care we can handle, and now it's time for the awesomeness, which is surgery, okay? So what is non-operative management? Everything short of that, correct? Hopefully that's a better way of explaining it than I did before. But I will tell you that non-operative management is things like NSAIDs, RICE, elevation, right? Activity modification, okay? What other kinds of things? Injections, medications, okay? Walking aids, assistive devices. Good to go? Okay? Corticosteroid injections is in red. Do you inject into tendons with corticosteroids?
No.
No, never, ever, 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 ever. Unless you want the patient to have surgery, right? And then inject into tendons. That's a joke, but don't do it, okay? Do we do steroid injections into joints? All the time, okay? But make sure you're in the joint and not in the tendon, okay? And that's it. That's non-operative versus operative. Again, this is not meant to be tricky, okay? So fracture management, now we're in the surgical world. We're in the awesomeness, okay? So surgery, as you can see there, there's open fixation and there's closed fixation. Otherwise known as instrumentation, right? These are instruments, right? These are implants, these are screws, plates and screws, okay? So it's just like it sounds. On the right there, you see an incision. You can literally see a lot of anatomy, right? You go right down to the bone, you visualize the reduction, you put the plates, you put the screws, you close, you take post-operative films, you high five, you go home. Okay? Same thing on the left there, you did surgery, right? But you didn't do a big incision. You didn't visualize anything of significance. You did it from the outside in. Does that make sense? And you can still see the imaging there, right? Where they got the reduction, they put those instruments in there, okay, the instrumentation, and they got the reduction. Any questions about operative versus non-operative? Okay. So, what is fixation as far as instrumentation? Again, it's putting things in patients that they were not born with. Okay, you see that rod there on the top left? On the bottom left there, you see the plates and screws. On the right side, you went from the outside in. It's still fixation, it still involves instrumentation, but it's from an external application. Make sense? Okay? Now, just because you do external fixation, do you think that maybe in the future you may have to do internal fixation? Yes, but just understand the difference, that's all. Good to go? Yes, sir.
Are we gonna go over why one is better than the other in a certain situation?
I will talk to you guys, that's a really good point. You didn't really address it earlier. I encourage you guys to ask questions. Okay, but a lot of times I get super excited and start going into all this crazy stuff because I've been teaching surgical stuff for so many years. So I have to cut myself off, okay? So if I tell you like about something and I want you to know a little bit more about it, I will let you know. If I'm going off on a tangent and I can recognize I'm about to do it, I will tell you, hey guys, this is just for your information. This is just for your enrichment, okay? Make sense? That way you know what's testable, okay? Everybody wants to know what's testable. Is this gonna be on the test, right? Did I answer your question? Yes, maybe? All right, any questions, any other questions about surgery versus non-surgery, surgical versus non-surgical treatment? What is surgery? What is fixation? What is not fixation? What is closed? What's open? No? Okay, hopefully I did a better job explaining this time. So, drugs, okay, we'll talk about two specific things in this chapter. And so the two things for now are NSAIDs and with non-steroidal anti-inflammatories and steroidal anti-inflammatories, right? Which is steroid injections, corticosteroid injections. So when we talk about NSAIDs, we talk about using those to treat inflammatory conditions, okay? Things like arthritis, bursitis, tendonitis, okay? All the itises, okay? Do they have side effects? Do they have a profile that you need to be aware of? Yes, 100%. A lot of GI have said. Some of them increase patients' cardiovascular risk, right? So it's not without consideration. But we do use them for analgesic effects as well, and antipyretic effects. What is an antipyretic effect? Fevers, fever reduction, perfect, okay? Excellent. So, again, you can see they're listed. I will tell you that dyspepsia tends to be kind of the one thing that people worry about. So if you're gonna give somebody an NSAID, you might give them something for the stomach issues too. Make sense? Okay. So you do not want to increase the risk of heart attack or stroke though. And you wanna make sure you understand how well their kidneys function and how well their liver functions before you start giving them medications, willy-nilly, right? Good to go. Any questions about that? Okay, corticosteroid injections, I told you, like I mentioned earlier, they are the mainstay for articular conditions, right? Intra-articular conditions, right? Like a lot of things like knee, ankle, we do a lot of steroid injections, right? So, extra-articular conditions as well, but again, being careful to select what you're doing and not injecting into a tendon. Okay, because you see those conditions there where it says overuse, athletic injuries, bursitis, tendonitis, never into a tendon though, right? Of course not. So they provide pain relief while avoiding the side effects, the systemic side effects, excuse me, of using oral steroids. Okay, are there certain conditions you'll use oral steroids for? 100%. Okay, could they have secondary effects? It causes the patient to have relief of their back pain, for example? 100%. We don't typically use them for that. Okay? Adverse outcomes. You guys go through some of this in pharmacology, I'm sure. But anytime you do a steroid injection into the skin, right? You're going to break the skin to go into whatever it is, whether it's superficial, whether it's intra-articular. It has certain side effects, things like skin dimpling, blanching of the skin. You can see both those things in that picture right there, right? You guys see that area right there where it's dimpled like that? Do you think that's permanent? Yeah, maybe, right? That's called atrophy, right? What other things? The skin discoloration, like I said. Tendon rupture it increases the risk of tendon rupture. And another thing which is controversial is chondrotoxicity. What does chondro mean? Cartilage, right? So it may cause, it may cause the patient to have accelerated breakdown of cartilage. And that's what that picture right there is supposed to show. Okay, you see that picture where there's like, we call those divots, right? There's a divot in the articular surface. Okay, that's probably a knee, okay? So you're looking at the undersurface of the knee, right? So say the undersurface of the femur, okay? So that can actually accelerate that. Good to go? So what is a splint versus a cast? I'm not trying to insult anybody's intelligence. I'm just trying to explain to you guys that when you guys get to block 4 and we start talking about a splinting lab, we're not doing casting, right? So what's the difference? So splints are temporary, they're non-circumferential, and they can be removed if there's a concern for some kind of increased swelling, some kind of increase in, or excuse me, I should say decrease in neurovascular status, but not a cast, right? The cast tends to be more permanent. It does not allow for the swelling, right? It's circumferential. And the other thing, risk with cast is that they can have more skin breakdown and a risk of infection if that occurs. Good to go? Okay. Any questions about that? Okay. How are we doing? Keep going?
Sir.
Okay, I got this one thing and then we're literally done, okay? For today. Okay, so we're gonna talk about the first main topic now. So, again, this block is all about what? General orthopedics and also spine. Okay, so the first condition we talk about is osteoarthritis. If you look in your syllabus, it says in there that the exams for each block will not be cumulative per se. They will be based on all the topics for that block and that block alone, okay? But osteoarthritis goes through all the blocks, right? Because you can have osteoarthritis of multiple joints, okay? And osteoarthritis tends to be progressive, right? So this is a good example of a condition that you should be well versed in, okay? So osteoarthritis, excuse me. So what is it? Progressive, irreversible condition involving the loss of articular cartilage that leads to pain and sometimes deformity. There's your definition. So when we talk about osteoarthritis, again, it can be progressive, right? So a patient can say, well, I used to have this level of pain, and now my pain has worsened, and my functional capacity has decreased, right? So that gets to that point right there. It's the leading cause of impaired mobility in the elderly. Do you think that's a fact that may show up on a PANCE exam someday? Yes? Yes? Anybody? Okay, awesome. I know. So types, primary and secondary. This is what I'm telling you guys. Understand the difference between primary and secondary osteoarthritis. So primary, you can't prevent it. There's nothing you can do to prevent it, right? They have factors like aging, genetics, obesity. I just got the bad genes. The patients will tell you that, right? My parents had diabetes and they had osteoarthritis in both knees and both elbows and all this craziness. You can't prevent it. It's something that's progressive, irreversible. Now, the other one there is what? Secondary, right? When you think of secondary, always think post-traumatic too. Was there a preceding injury that occurred that led them to have the possibility of having that secondary arthritis? Okay, what are some examples? Like we talked about earlier, fractures, right? And other disorders like osteonecrosis. Okay? So remember when I told you guys it was osteoarthritis? So that's bone arthritis. Did everybody agree? Okay, so bone arthritis. Okay? And we'll talk about different kinds of arthritises, but remember I talked to you guys about those reading sheets. Start understanding the difference between the different types of arthritis. Arthritis is not arthritis. Arthritis literally means inflammation of a joint, but it doesn't tell you what. The osteo tells you it's bone, and it involves cartilage, right? Cartilage lines the articular surfaces of bone, right?
Yes.
Yes. Okay, I think so. The answer is yes. Sorry, I'm not as sharp as I normally am today. I very little sleep. So, clinical symptoms. Most common symptoms are stiffness, joint pain, and what? Deformity. Okay? Stiffness, joint pain, and deformity. So when you guys are doing your OSCEs and your mock exams and your junior clin core and all those courses, are you going to ask the patients, do you have stiffness? Right? Do you have joint pain?
Yes.
Yes, you're gonna. These are kind of questions. So I always tell people, start thinking about the term snap, crackle, pop. When you think about snap, crackle, pop, you're asking the patient about different orthopedic conditions. Okay? Don't just ask them about their nausea, vomiting, fever, chills, diarrhea, chest pain, shortness of breath. Ask them about the snap, crackle, pop, because it's an ortho case. Okay? Make sense? So common locations, fingers, knees, hips, and spine. All those things, weight bearing, and you use your hands a lot?
Yep.
Yeah. So certain conditions, remember I told you guys about temporal factors? If you're reading these clinical scenarios when you're going into these PANCE questions practices, and the PANCE, and it tells you it's a 78-year-old seamstress who has pain in her hands, and et cetera, et cetera, et cetera, do you think it might be an arthritis question? Potentially, right? So start thinking like that, okay? And then we get into that snap, crackle, pop. Grading, catching, grinding, due to those osteophytes and cartilage fragments. Okay? What's an osteophyte? Bone spurs, right? It's a phyte that is osteo. It's bone. Good to go? Okay. And cartilage fragments. So do you think if there's wear down of cartilage, that some of that cartilage might break off and be floating around inside the joint? Yes, all the time. In orthopedics, we call those chiclets. Right? And if the patient's having that snap, crackle, pop, and it's causing them to have a lot of discomfort, and every once in a while their knee catches, do we go in there and fish the chiclet out every once in a while? 100%. We call it scoping for dollars. Okay? So, some of the adverse outcomes of disease, this is a term that's used commonly in your book. I don't necessarily like it, but it's used. It basically means what's the bad stuff that can happen. Okay? Pain, deformity, loss of joint motion, loss of limb function, okay, and joint instability. Are we good with that? Okay. So, on physical exam, an effusion may be present. What's the difference between superficial swelling and effusion? Not your question. So an effusion usually involves some kind of articular component. Make sense? Is there some kind of a pouch, right? Like the suprapatellar pouch of the knee, okay? And then superficial swelling is completely different. So you may think of things like cellulitis, superficial infection, things like that. So effusions can be more significant, correct? If you get enough swelling to get an effusion, do you think they may have decreased range of motion?
Yep.
100%. So think about those things as being separate and different, okay? Can effusions come and go? Yeah, if they rest, they elevate, right? We talked about NSAIDs, rise, elevation, all that stuff. If they elevate, the swelling may go away. If they have infection and they elevate, does the swelling go away? No, it gets worse. Then we start hacking limbs. Make sense? If you wait long enough to not refer to us. Okay? They may have crepitus. What's crepitus? Yeah, it's like grinding, right? It's that grinding sensation a patient will report to you, and well, more specifically, crepitus is something you find on physical exam. So is that snack, crack, or pop I was talking to you guys about? Yes. You had a 50-50 shot? Yeah, try again next time. So joint line tenderness. So on physical exam, are you going to ask the patient if they have tenderness on the medial aspect of their knee or lateral aspect of their knee? And then you're going to palpate those landmarks, and you're going to say that the patient has medial or lateral joint line tenderness on exam? Yes. On their physical exams, that the finding will be lateral joint line tenderness with this exam motion? Yes. Like in McMurray's. I'm jumping ahead. I'm getting excited. Okay, so x-ray findings. I came up with an acronym. I don't know if I came up with it. I stole it shamelessly. I stole it, right? But the x-ray will find joint space narrowing, osteophytes, that's that bone, right? Those bone spurs. Sclerosis, is that white striping on the surface of the bone that indicates areas of friction, pressure, wear down, high usage? Yes, that's what it is, okay? Subchondral cysts, it's subchondral. Chondral means what again? Cartilage. So are those cysts going to be underneath the cartilage or over the cartilage? Underneath. Over doesn't make any sense, right? So there you go. So that's what you're going to see on x-ray. Good to go? Oh, sorry. What's in red?
Weight bearing.
For all lower extremity injuries. If you get a question on pants and the choice is between a weight-bearing film and a non-weight-bearing film, and then 3 other choices that don't make any sense, which one's the right answer?
Weight bearing.
Weight-bearing. Okay, good to go. So this is it, loss. This is how you're going to remember osteoarthritis from now to the day you retire, which I keep saying I'm going to do, and I've been through decades. So, right? But loss. Loss of the joint space, osteophytes, those bone spurs, sclerosis, that white striping, okay? And subchondral cystic changes. There's a picture for you guys. You're welcome. That shows some of that stuff. Will that look different on x-rays? Yeah, it's not going to look as colorful, right? But we'll get into that a little bit more as we go into the specific body parts. Okay? I think we should take a break. We're losing people. Let's take a 10-minute break and we'll start up again, and we'll be done shortly, okay? All right, hopefully you guys are getting a sense of how I do things. I tend to be up-tempo, a little bit jumpy, but I just want you guys to be excited about this topic, and I'm trying to keep it entertaining for you guys as well while we learn, okay? So please throw questions out there. So I had a question asked by O.C. Brown during the break. It's like, why would you put on an external fixator? You know, why would you use external fixation versus internal fixation when you can just fix the problem? Okay? Suppose somebody sustains major trauma, meaning they've been in a car accident, right? And they have all kinds of intra-abdominal injuries. Oh, and by the way, they broke both femurs, their wrist, a couple of facial bones, et cetera, et cetera, et cetera. Which one do you think is going to kill them? The intra-abdominal stuff, right? So external fixation, a lot of times we use it for temporizing, okay? I put on external fixators, you'll get me telling war stories, but I was the commander of a shock trauma platoon, forward deployed, Helmand province with the Marine Corps, okay? So somebody presents, they have a fracture pattern that's unstable, you can't just ship them out like that, right? You can't have this floppity limb, okay? But you treat all this stuff that needs to be stabilized, you put an external fixator on, you bring the bone back out to length, you put it approximately where it's supposed to be, and you say, okay, we'll get to that later. Make sense? Okay? And then internal fixation is the ultimate awesomeness, right? That's where you go in, you saw a bone that was broken, and now you made it more anatomic. Right? Anatomic is it's what we strive for. But a lot of times we tend to be humble and say near anatomic, right? Because you can't quite get it perfect. Okay? Is that a better job of explaining that, sir? Yeah, okay, excellent. So please continue to ask those kind of questions. That's really, really good questions. Okay? Can external fixation be used for longer periods of time? Yes. But again, if you can do the surgical management initially, you will do it. But sometimes the patient's condition, whether they're stable or unstable, remember, precludes being able to go right to the awesomeness. You have to treat the soft, squishy stuff first. Right? Make sense? They kind of need their brain before they need their foot, right? Some people don't have either. So. All right. So, moving on. All right, I'm going to cover a few more topics and I'll let you go. Why do I put you on break? To bring you back. Because we want to get done with this topic today. Because I will tell you this. Osteoarthritis is something, again, you will see very commonly as you go through all 4 blocks. Okay, so if you can't pick the right answer out of a question, by the end of block 1, you're going to continue to struggle. So let's go ahead and just knock this out and get an understanding of what osteoarthritis is versus things that are not osteoarthritis. Things that have radiculopathy, things that have infection, right? Because everything can't be osteoarthritis, right? So what's a body part? We'll start with soon the cervical spine. So C-spine, right? How many cervical vertebrae do you have? 7, right? Unless you're weird, you have 7, okay? So if you have 7 vertebrae, can you have degenerative changes at any level? Yes, right? Are there more common levels? Yes, but we'll get into that later, okay? But cervical spine osteoarthritis is literally called DDD, degenerative disc disease, AKA cervical spondylosis. Now is the time when I give my speech about knowing the difference between spondylosis, spondylolisthesis, et cetera, right? Because everything's not the same, correct? So this is, when we're talking about degenerative disc disease, or osteoarthritis of the cervical spine, we're talking about cervical spondylosis. Make sense? What is an osis? It's a condition, right? It's a pathology. Make sense? Later on, we're going to talk about listhesis. When we talk about listhesis, we talk about abnormal motion, right? Slippage. I'll table that. But just understand that right now we're talking about osteoarthritis of the cervical spine. Good to go? Can they cause neck pain? Yes. My neck is killing me right now. I had to move the entire basement of my house into a storage unit. Running on fumes, right? But that's just because I'm old and I have degenerative disc disease from carrying packs and doing all kinds of stupid stuff. So, can you have radiculopathy? Yes. Radiculopathy is what? Yeah, radiating neurologic symptoms, right? Is radiculopathy neurological pain? Yes. It's not pain from superficial swelling. It's literally nerve tract pain, right? And it radiates, correct? Okay. Andromyelopathy. What is the difference between radiculopathy and myelopathy? Look at the word. Myelo refers to muscle, right, or soft tissue. You were going to say it. You said it. Yeah. I can't take credit. Right? And it's pathy, right? So it's a condition. It's a bad condition. It's pathologic, right? So when we look at that x-ray right there, what is lost again? What's the L?
Joint space.
What's the O?
Osteophytes.
What's the first S?
Sclerosis.
What's the fourth S? Or second S? What's the fourth letter? Yeah. So bone cystic changes. Do you see bone spurs there? Yes. Why? Because they're labeled. Okay. Do you see disc space narrowing? Yes.
Yes.
So does this meet some of the clinical characteristics of osteoarthritis? It does. So that's what we're talking about here. Okay? But just understand that just because they have osteoarthritis, high five, you made the diagnosis, they have degenerative disc disease, aka cervical spondylosis, aka what? Osteoarthritis of the C-spine. But do they have neurologic deficits? What does that bottom line there say? Full, narrow, and gait. What is gait?
Walking.
Walk. Watch and walk. It's literally that, right? Is that heel to toe thing? Is that walk on your tippy toes thing? Yes, okay. I am all about physical exams, so I'll throw that in there whenever I can. Will those be on the test? Yes, okay. I'm giving it to you. I'm telling you right now, know your physical exam, okay? We'll practice it together, we'll learn together. Promise, promise, promise. So now we're gonna move to the shoulder. The shoulder has some specific terminology you'll see thrown out there. And I throw these in here because on PANCE exams, they love buzzwords. Pathognomonic, right? Things that are like red flags or like indicators of a certain condition, right? It goes with this. All right, so posterior joint line pain, okay. I would say that most patients that have osteoarthritis in the shoulder, they just kind of hurt here, right? But when you say what? When the one finger points to me where it hurts the most and they point posteriorly, that's more consistent with osteoarthritis of the shoulder. Good to go? So what's that word I was telling you about? Goat's beard. Why is it a goat's beard? If the picture was clearer, the resolution there is not the best, right? But you can see how there's a little chin there at the inferior aspect of the humeral head. Make sense? So that's why it's called a goat's beard. That's very specific to shoulder osteoarthritis, okay? So if you see some kind of mention of that, then think of that. The other thing you want to remember, and I'll foot stop right now, jump up and down, light myself on fire, right? If you see superior migration of the humeral head, do you think they might have a rotator cuff tear? From now to the end of eternity, yes. Okay? So if you see that in some kind of clinical vignette scenario, that they have superior migration of the humeral head in relation to the glenoid cavity, right? Because we'll get into more anatomy stuff. But the glenoid cavity is the cup, and the ball is the humeral head, right? So that's what we're talking about here, okay? That's specific to shoulder osteoarthritis. Questions about that? Do we see evidence of loss there? LOSS? We do. So that all stays the same, correct? Good to go? Okay, bear with me. Elbow, osteoarthritis of the elbow is one of those things that we try to say, let me take 100 steps back, the patient still looks good, yeah, we're not gonna do anything, right? But when a patient has significant loss of range of motion, or maybe we see those floating chiclets in there, bless you, then we may wanna do something, right? Because is it important to be able to go through a drive-through and reach for your change? Yes. Is it important for women to be able to snap their bra on, or men? I'm not judging. Yes, right? Is it important to be able to wash the back of your head, or do other functions that require you to have hygiene, right? Yes. So if they have elbow loss or range of motion, sometimes it will drive us to make surgical decisions, right? So range of motion is critical to quality of life. Okay, what is a block to motion? So if you tell somebody to extend their elbows, and all of a sudden the right elbow, right, is stuck here, right? And you're able to grab it and kind of manipulate it, you feel a pop, and then you can extend it just a little bit more. There's a chiclet floating in there potentially, right? So maybe you go in there and fish that out, and they have a little bit more increased range of motion, less pain, right? Do you think it's painful when that chiclet gets engaged? That's painful, right? So again, that's why it's important to understand when you're doing range of motion, do they have normal symmetric range of motion, one side compared to the other? Make sense? So start thinking in your mind, anytime you're doing a physical exam, don't just do one side, unless, just don't do it, right? Compare it to the contralateral side. That's gonna become second nature to you guys. Good to go? All right, osteoarthritis of the hand. Here's some PANCE, low-hanging fruit. Okay? PANCE, low-hanging fruit right there. Probably already seen it. What's the difference between a Heberdine's node and a Bouchard's node? Heberdine's is the dip, and Bouchard's is the pip. Right? So that's what you're gonna see. So if you're given a clinical scenario that describes this stuff, not only is it describing osteoarthritis, but they're specifically describing arthritic changes to specific joints. Good to go? So burn this into your mind, into your brain, I should say. if you have not already mastered this concept, okay? Do you think this is something you might see on a PANCE test? The chances are high. Okay, and you see those subchondral cystic changes in that picture on the right? Yes, so there we go, okay? Is this stuff you see in young people or old people? Older than me, okay? But yes, older populations, okay? Takes a while to develop these. Do these involve the wrist or the MCP joints? No. We'll talk about conditions that involve the CMC, the MCPs, the wrist bones, and things like that. This is not that, okay? So remember I told you those reading sheets, you start differentiating how things differ from each other. This is how they're different. Good to go? So when it comes to osteoarthritis of the wrist, the most common is post-traumatic. Somebody sustains a fall at some point, right? Parachuting accident, I don't know. They have a fall outside of a moving vehicle or something like that. They never seek care. They get into clinic. You get x-rays and you see that black arrow right there, how it shows how there's loss of joint space there. There's some subchondral cystic changes. There's some sclerosis there. So that's arthritis, right? Okay, is there much to do about that? Not necessarily. All right, but again, what are you gonna do? You're gonna do a full physical exam, check the range of motion, check all those other components we talked about, and then develop a management plan, okay? Do we do corticosteroid injections for wrists? Yeah, it's a joint, right? It's a bunch of little joints, correct? Right? So if you don't know what you're doing, don't do them, but we do them all the time, okay? Good to go? Questions about that? CMC joint, this is one of those things, carpal metacarpal, right? This is not the tarsal metatarsal. This is not the carpal tarsal metacarpal. I can't even make stuff up. But I've seen people put stuff down, I'm like, yeah, that's not a thing. So understand what the carpal metacarpal joint is, because is that the first MTP? Metatarsal phalangeal joint? No, it's the carpal metacarpal joint. So the conditions and the diagnoses are different. Why do I say that to you? Because this is the first time I'm telling you guys, read the question. Read what the question's giving you, the scenario's giving you. Where is the injury that's being described? Where is the pain that's being described? If you're describing pain to the CMC and they have a positive CMC grind test, is that the same thing as first MTP? No. Okay, makes sense? Okay, so what's the grind test? Well, it's as demonstrated there. If you take your thumb, right, and you grasp it with your other thumb without pushing the clicker, okay? And you literally do a mortar and pestle effect where you're pushing down into the joint and you're twisting and turning and you're grinding, and that's causing pain to the patient, right? That's a CMC grind. Everybody knows what a mortar and pestle is? Yes? Okay, and that's what that picture's denoting there. So did I just give you a special test?
Yes.
Do you think that's testable and something you should be paying attention to? Yes. Hans loves these buzzwords. What is that? So buzzwords, right? So yes, they'll have swelling. Yes, they'll have enlargement, right? Is that, if you have bone spurs, do you think it might show bony overgrowth in that joint? Well, the picture shows you the bony overgrowth, right? So you can see it there. Can you have instability of the joint? Yes. Can you have subchondral cystic changes? All that stuff? Yes. But one thing with specific for thumb CMC joint osteoarthritis is that the patient will describe that they have pain with pinching and grasping like this, right? Like a pincer. And they have weakness. They're unable to maybe hold a piece of paper between their thumb and their fingertip, their index finger, and then you try to pull it away, they have weakness. Does that make sense? Okay, so weakness with pinch and a positive CMC grind test, that's an indication that they potentially have osteoarthritis with the CMC joint. Are we good with that? Okay. Right. Hip osteoarthritis, the bane of your existence as an active duty or weekend warrior PA. Right? I'm just joking. I was in the reserves too, so I got love for the reserves and the Guard. But I'll tell you why, because if you get, most people that come in for hip pain are the young people or old people for primary care?
Old.
Old. Then what can you do for these people? Not much,
Exact.
right? And we'll start talking about definitive treatments. And if they're young, you can do even less. What you'll probably do is you'll send them on physical therapy. But not before, as astute clinicians, you guys order what? X-rays, right? Every patient, right? Because they describe anterior pain, that's the most common. And when I say anterior pain, I mean, you tell the patient again with one finger, point to be where it hurts, right? And they point right about here, right? Right into that joint line. Not the groin, not the testicular or appropriate genitalia for their designation, right? They point right into that joint and say it's deep in there. That's the pain I'm talking about, right? And when we get to hip, you guys will understand what I'm talking about. You gotta know where the pain is. It's not just hip pain, right? You get a lot from the history. They said they have anterior hip pain, maybe arthritis. They're 70, right? If you're saying lateral joint pain, your differential diagnosis changes. And if you're saying posterior hip pain, well, now it's something else, right? Does that make sense? So it's important to zero it in on your history, like we talked about earlier. Okay, so how are they gonna walk? You will see this again. They will walk externally rotated. Why? Because when they internally rotate, it causes impingement, and it's painful. Are we good with that for now? We'll get more into that later. But they will walk in external rotation with limited internal rotation. If you look at this picture on the left here, does that look like a normal ball and socket relationship? There and there? No. It looks like it's collapsed, right? That's pretty severe osteoarthritis. Do you think they're gonna be able to have full range of motion? No. And the one thing that's limited very often is internal rotation. That's the first thing that'll clue you into that. Do you think there's a special test that goes with that? Yes, and we'll get into that. But this is where I'm introducing this concept. Okay? Knee osteoarthritis, again, another condition you guys see very commonly in the military. And there are some treatment options, but no real good ones for young, consider myself young, but for people that want to remain on active duty, right? Okay, so the most common malalignment that you'll see is genu varum due to that collapse, that loss of joint space, right? Everybody can see on those with those red arrows where the joint space has collapsed medially, correct? Yes? Not laterally, but medially. So that's the most common. So if it collapses in that manner, that fashion, is that varus or valgus? Varus. It's on the slide. Okay? So that's the most common presentation. Are we good with that for now? Don't worry, we'll get into varus versus valgus later. I promise. But just understand that varus is genu varum, right? Is the most common deformity with knee osteoarthritis that we see with alignment issues. And it's due to that loss of joint space. Okay? Did I mention anything about ligaments? No. This is all has to do with collapse of the articular cartilage. This is osteoarthritis we're talking about. Good to go? Okay. So here's some advanced imaging. You're welcome. So if you look at the left there, that's that little area with the tick mark and the arrow, the white arrow, right? That's an area of delamination or an area where the cartilage is essentially worn down. If you can't see it, don't worry. I won't give you, this is not radiology. You won't get those one slide questions on a test. You're welcome. But I just want you to understand that sometimes when you see that on MRI, it presents a certain way, right? That picture on the right, that's where we're scoping for dollars potentially, right? We stuck a camera into the knee joint and we're literally staring at the defect. We're looking at it, okay? You see it on MRI, you're like, there's some surgical indications there. We go in there and we see it, okay? That's it. This is for your enrichment. You will not get questions that have these kind of pictures, okay? But I do think it's important for you to understand what things look like on advanced imaging, okay? Good to go? Who wants pictures? Who wants those kind of questions on the exam? Nobody? Okay. Not even one? I had one taker, it was a Marstock guy, he was crazy. He's not dead, he's still crazy. But anyways, so treatment options for arthritis, limited, right? Lot of physical therapy, a lot of activity modification, a lot of NSAIDs, a lot of rice, right? A lot of doing different kinds of NSAIDs, okay? A lot of different kinds of physical therapy, right? We tell them to say, lose weight, right? You put less pressure on your joints, lose weight. We tell them to do low impact activities versus high impact activities, right? Low impact activities, things like elliptical, swimming, okay? Swimming's great, right? High impact activities, well, jumping out of a helicopter, that's high impact, right? Running, jumping, things like that, okay? And then if they don't get any relief, and they tend to be older patients, because what can corticosteroid injections cause? It can advance cartilage wear down, right? So we tend to try to avoid steroid injections in younger people. What is the definition of younger? 35. I knew that question was coming, so I'll just tell you what it is, okay? 32, 35, somewhere in there. Over that, you're considered old. Yeah, so I'm double old, so. But if you've done the treatment, they're not super young, they've kind of failed everything else, you're thinking to yourself, maybe there's some surgery in their future, let's try a steroid injection. Perfectly reasonable. If you're trained to do them, and you feel comfortable doing them, do them. Put the steroid into the joint, please, not into the tendon or surrounding tissues, okay? If you guys are out there in phase 2, practice, right? But just understand that, is that curative? No. So they may only get relief for a day or two, maybe 2 weeks. So once they start getting to a point where they get little to no relief, especially no relief, do you think you're going to refer them to someone like me?
Yes.
Well, I'm here, so you won't refer it to me, but you're referring to my buddies over at BAMC, right? And they'll talk to the patient about some surgical options, okay? And that's what it says at the bottom there, right? Because what is the definitive treatment? It's in gold. Do you think that's something you might see again? Yes, it's in gold. Definitive treatment is arthroplasty, right? So we go in there and we replace the joint. That's why it's called a joint replacement, right? So we can do hips, we can do knees, believe it or not, we can do ankles. Not the best surgery in the world. Patients do terrible, right? We can do joints in the fingers. I mean, there's all kinds of stuff out there, okay? But the definitive treatment is what? Joint arthroplasty or arthrodesis. Let's go ahead and dig into this. What's the difference between arthroplasty and arthrodesis? Arthroplasty is a replacement. Arthrodesis is a fusion. So with arthroplasty, you're trying to restore full motion potentially, right? So you're trying to replace the joint. Not gonna make it like it was before, right? You have a lot of parts that are not native to the patient, but it still allows for motion. And arthrodesis is a fusion. It actually will take away motion at certain joints. Make sense? Okay, so arthrodesis is a fusion, so it will actually decrease the amount of motion. But guess what? If you have pain in a joint and you fuse that joint and change the mechanics and they have less pain, is that something that some patients would accept? Probably, right? So arthrodesis is very common for ankles. I did mention earlier that arthroplasty is a possibility. I'm not sure the science is there yet. The implants are there. The numbers definitely say patients don't do well. Because if you replace the joint, does somebody want to continue to do high impact activities potentially? Yes, trust me, they'll try to run through it, right? So proper patient selection is important. But an arthrodesis will take away that, right? But then it also limits their lifestyle, correct? But the definitive treatment is what? Arthroplasty or arthrodesis? Questions about the difference between arthroplasty and arthrodesis? Arthrodesis. Say that 5 times fast. So obviously, adverse outcomes of treatment, NSAID risks, we talked about those. Injection risks, right? We talked about those in detail. Post-op complications. Just because you send them to ortho and they get joint replacement, are they out of the woods? No, it's a long process of recovery, and the risk of infection is definitely not zero, right? Especially if you're diabetics, right? Diabetic patients, whew, Thankfully, we don't deal with too much of that in the military, but civilian practice, whew, yeah. Everybody wants to be an athletic or Olympic runner when they're 250 pounds and 4'10". But referral decisions are red flags. So for you guys, this is a concept that's being introduced now. This is where you start thinking to yourself, is this a patient that I'm going to manage in primary care? Or at what point do you start thinking to yourself, this is a patient I need to refer now? Okay, so this is what it's talking about. You've done all that conservative stuff, and now you're like, what else do I got? I got nothing. You order x-rays, right? Especially if the x-rays are older than a year out. Order new x-rays, and then you refer them to orthopedics. Good to go? Okay? Limited functional range of motion. I'll keep it simple for you guys. Work, play, sleep. When somebody has their work, play, or sleep significantly affected, they'll come see you. Right? So work and play for military people tend to be the same thing sometimes, right? So work, play, and sleep. Okay? Older people can't sleep, they'll come see you and say, I want a referral. I think I'm ready to get my total joint.
The inset risk?
Say again?
The inset risk? What was that?
The inset risk, so remember the dyspepsia, the cardiovascular risk?
Oh, so it's too much on the inset.
Yeah, absolutely. There are some, I'll just throw that out there now, because I usually get a question about this. So yes, there's been studies done on mice, right, that says that prolonged NSAID use can cause a decrease in bone mineral density, things like that, can inhibit bone healing, things like that. I would say if you're about this big and furry and you have a tail, I probably wouldn't give you NSAIDs, but otherwise we use it judiciously. So what does that mean? That means you look at the patient's history, you look at their med list, you look at their insurance plan. No, I'm just joking. You look at you select the right treatment for the right patients, right? So what does that mean? That means that there's different kinds of NSAIDs, right? You guys acknowledge that, right? There's Celebrex. Does Celebrex tend to be safer on the heart? Yeah, it does. So we use it very commonly, okay? I'm gonna walk over here for a second. So, yeah, so there's different kinds of NSAIDs out there, right? What's the NSAID that we give everybody? Give this to the soldier, have them change their socks and rub some dirt in it? Motrin, vitamin M, right? So there's different stuff, right? Okay, makes sense? Yeah, did I answer your question?
Yeah.
At some point? Yeah. Okay. All right, so what did we go through? We went through this. You guys can read, I won't read it to you. Okay? That was a lot about one condition. Why do you think that's so important? Because if you zero in on what this is, then when we talk about other conditions, you know it's not this. Right? Because you understand this. Make sense? Because in every topic that we discuss, when we start talking about specifically shoulder conditions, and specifically elbow conditions, and specifically knee conditions, you don't tell me everything's arthritis. Everything's osteoarthritis, right? Because some things can be rheumatoid arthritis. We'll get there. Good to go? So if you get a radiographic finding after a 34-year-old male has knee pain for 2 months preceding a fall, are you going to tell me that's arthritis? Maybe. It's in a differential. But could it be a meniscal tear? Yeah, could it be an ACL injury? It could be a lot of other things, right? So don't just be like, it's all arthritis, right? Now, if you're seeing primarily old people, you're probably going to see a lot of arthritis, okay? But I'm just saying, don't tunnel vision your thought process, okay? That's all I have for you guys today. We'll meet tomorrow.